So thank you very much and welcome all. I'm very happy to welcome you on our webinar on surgically induced lymphedema, global impact and current treatment options. This is an ESSO webinar developed from the ESSO Education and Training Committee, and I'm Dr. Maria Vasileva, and I'm a breast surgeon from Bulgaria. I feel the responsibility and honor, honestly, to moderate this webinar because in my country, lymphedema is a major problem. As a breast surgeon, I can say that unfortunately the procedures to decrease lymphedema risk, like sentinel lymph node biopsy, are not widely implemented and for sure are not standard practice in Bulgaria. There is lack of awareness and education for lymphedema, but also there are lack of specialists dedicated to lymphedema treatment and care. With this background, I felt important of this topic that need further discussion. And I see that all the participants tonight agree with me because we are happy to have almost 100 and hopefully more participants. I'm pleased to be this evening with two great colleagues of mine, and I have to thank ESSO that gave me the opportunity to know them. They are Dr. Carmela Caballero and Dr. Naza Sayed. Dr. Caballero, she's an ASAC Path Chair and Senior Medical Advisor in the Breast International Group. And Dr. Raza Sayed is a member also of the Education and Training Committee of ESSO and Surgeon in Royal Marsden Hospital in London, UK. I will let them to introduce our speakers now. So please, Carmela.
So hello to everyone. Good evening, good afternoon, and good day to everyone. I am Carmela Caballero. I'm, as Mariela said, from the Breast International Group. I'm very happy and really honored to be part of this webinar, and I'm very honored as well to introduce the first speaker for tonight. She is Professor Christine Moffat, who is currently the Professor of Clinical Nursing in Skin Integrity at the Nottingham University Hospital. She is also the chair of the International Lymphedema Framework. After her, we will hear from Arthur Bagonza, who is a specialist in public health in Uganda. He is also a research associate at the Makerere University and vice chair of the International Lymphedema Framework. Very pleased to welcome our speakers.
Yes, and hi everyone. I'm Raza. Originally from Pakistan as a surgical oncologist, but I'm doing my training fellowship over at the Royal Marsden Hospital in London. I'm very pleased to be part of this, and all the credit and effort put in has been by Mariela and all our wonderful speakers. So thank you to all of you, and thank you to all our participants who are joining us. After the first two talks, we will hear from our very special Petya Stoicheva, who herself is a lymphedema patient, and she's part of the Bulgarian Lymphedema Society. She will be presenting the patient's perspective in developing clinical trials in lymphedema, which is obviously one of the very important perspectives and clearly missed from certain studies that we see. And finally, Dr. Nella Devut, who's Associate Professor in Faculty of Movement and Rehabilitation Sciences in Leuven Cancer Institute. She will let us know about the new trends in research on lymphedema. So we will be very happy to hear all the questions from our audience. You can type them in chat, and we will respond to as many of them as we can after the lecture, and some will be answered during the sessions. And I believe our speakers will also be very happy to share their contact details for any further questions or collaborations. So over to you, Mariela, to guide us what to do next.
Well, I think just before giving the word to Professor Moffat, I will ask everybody who are participating in our webinar now to write where they come from in the chat. So we will see how much people we could reach, actually. And thank you very much for all this. And Professor Moffat, the floor is yours.
Thank you. Well, good evening, everybody. I hope you can see my slides okay. Good. I want to thank everybody for this opportunity. When Mariella came with the idea of this, the ILF was just so happy to be able to do something like this. And so precious that also surgeons are now really becoming interested in the issue of lymphedema. I myself have been a clinician for 50 years in January, but 40 years in this specialist field. And goodness me, lymphedema is truly a neglected problem. It really is. All these pictures in this first slide show you they are all patients and people I've seen around the world. So I'm really, really privileged to be able to share a bit about what ILF is trying to do as one of many groups of people trying to help the situation. So I will tell you a little bit about the work. Okay. How do I move the slides? You know how I move the slide? Okay. So ILF is a registered charity. We are a UK registered charity, and we've been in existence since 2009. And our mission and our vision is simple but huge, which is to improve the care and treatment of people living with lymphatic and lymphedema-related conditions worldwide. And I know that's a big mission, but it's something that we are passionate about. We really believe this is only possible through partnership, and partnership at every level. From government, from policy, from WHO, right through all of the sectors that need to be addressed to try and improve this. And we try to be brave in the ILF and to say, let us look at these questions that everybody else does not want to look at. So we are determined to reach the WHO, to change their views that lymphedema is a neglected condition and is only in Africa and India, and to really raise the issue for patients. The treatment then in a little while will be available worldwide. So how do we work? So I said we're a registered charity. This means we are a not-for-profit, and we work with countries that approach us and who are wanting to improve the care in their countries. So we don't go out and seek countries, but we try to respond when somebody comes to us and we ask one thing, which is you believe in partnership, you work together in your country with professionals, with patients, with organizations, with the medical device company in policy. And this is the only issue that we ask of our frameworks. We have only over 30 countries now working with us in partnership. And we are set up with an international board, of which each framework has 2 board members, and they are the lifeblood of ILF. So they are the ones driving our strategy. We have international conferences. We have research programs, which is everything from epidemiology through to mixed methodologies like picture art with our children's. We are passionate about education. So I'm in Denmark running an Erasmus project at the moment. So we are really committed to this. We are patient-driven, and Petia from Bulgaria is one of the leads of our new patient advocacy program, and that's how important patients are. We are passionate about not only creating evidence, but providing good quality evidence and guidelines, and focusing also on rare conditions like children with lymphedema, which is truly a rare form. And having webinars, it's such a privilege to be asked to participate in something like this. And we, of course, have our website, which has all of our documents, and our commitment is for open access to be free for everybody. So this is our ethos. Patients are always and must be always at the heart of everything we do. So nothing we do, whether it's panels, whether it's conferences, is without patients. Every conference we have, there is a dedicated patient conference delivered and developed for patients by patients. Collaborative, multidisciplinary, deep respect for each other, recognizing we are all experts in our own area and it's only together that we can change things, and recognize it's dynamic, it's changing, and we need to stay abreast of that. and the idea of international collaboration, of course, which is why ILF exists in the first place. So for me, when I think of lymphedema, I think of the privilege I have had and I continue to have going around the world, seeing patients in so many different countries. So at the top left, you have a patient from Uganda with pneumoconiosis. The patient on the right at the top is a patient from India with lymphatic filariasis. But if you look at the bottom right picture, this is a young girl who also has lymphatic filariasis, but she's only 11 and she's found in Uganda. And the picture at the bottom is a patient from Denmark who ended up with an amputation with primary lymphedema due to uncontrolled sepsis. And then on the left-hand side, you have cancer, and cancer is a major cause of lymphedema. And there are so many causes, but the common denominator is these people are suffering with lymphedema, and it's often multifactorial. We recognize in the West, we've got issues of comorbidities. So in morbid obesity, we reckon that between 75 and 95% of people with morbid obesity have concurrent lymphedema, and they present us a huge challenge. And the issues of care delivery and access, they are a global issue. So there are many high-income countries who have no special centers. And of course, there are many low-income countries as well. So the spectrum of lack of care is truly worldwide. And as Arthur said when we were discussing earlier on, there is such a need for embracing self-management, supportive self-management models, and a growing recognition that this is a fast-growing area. So that the area of genetics in primary lymphedema, each year new genes are found, that we begin to have insights into primary forms of lymphedema. But it's also, if we look at it from a sociological perspective, one of these hidden problems, it's considered a wicked problem, not because it's evil, but because nobody has wanted to own it. A dirty problem because it's often associated with smell, with poor hygiene, and this leads to stigma, and it leads to people not wanting to invest in addressing these very, very real problems. And again, all of these slides on this picture are patients from around the world. The top picture is from a patient in Nottingham. The bottom picture is someone in India. And so it's truly a global problem. And we need to recognize that lymphedema affects the very poorest people. And these pictures are all drawn from my visits in India, where people don't have access even to running water. And you may say to yourself, well, what can be really done? Actually, some of the most stunning work is being done in India with very low income, but they are transforming the lives of people with lymphedema with an integrated model that is both allopathic medicine and Ayurvedic medicine. So it is not hopeless. We can do so much. But if we go back to the West, I think we are going to face an exploding issue because of our demographic changes. We've got increasingly elderly population, and that's where our highest prevalence occurs. Increasing obesity. This is going to mean that we have people with lymphedema occurring. And of course, we have to address the issue of obesity, not just the lymphedema, because unless you do one without the other, nothing will change. And as people become less willing to move and more immobile, so too is the risk of this affecting a lymphedema. Studies we've been doing in Saudi Arabia in neurologically disabled people have shown 45% of people with MS have got chronic edema and lymphedema. And the more we become successful with cancer, we still have people then facing a lifetime risk of developing lymphedema. So the issue of cancer and lymphedema is not going to go away. And the greatest problem in the world is those with lymphatic filariasis living in India and Africa, and it's spread by the mosquito. So we have this globally silent epidemic occurring. A huge cost. These are some figures I just drew from some work we've been doing in Europe. but 9% of people end up having to stop work completely because of lymphedema. This has a massive impact on earning potential, on the cost to health services, and we estimated that managing cellulitis a year is at least 2.3 billion euros. And if we were to effectively treat patients, we could massively reduce that cost just by providing effective care. So we can see we have the potential to influence governments to be able to show, but we also have to get people's hearts open to recognize that this is something that can be done. We can treat these patients. We also, as clinicians, have a difficulty in being able to describe lymphedema in the same way. And this is a really big challenge. So we need to work to have ways of classifying and describing people so that we can do clinical trials that allow us to compare and contrast. And some of the measures we use are very simple, like the pitting test or the Stigma sign. But you can see just in this picture alone just how diverse and heterogeneous the population are, and that provides us with challenges. So one of the things that the ILF attempted to do, and we started this work 15 years ago, I was asked the question, what is the biggest challenge? Of course, there are so many, you could almost say, where do you begin? But I was sure that one of the biggest problems, we did not have epidemiology, except in very characterized populations. So actually, in the breast cancer world is the largest amount of evidence about breast cancer-related lymphedema. We're gathering much more data. But we didn't have data about the mix of patients that we see in many healthcare settings. So we decided to try and develop an epidemiology study called LIMPRINT, which is about prevalence and impact. And it was to try and characterize the size and impact, dispel some of the myths that it's either a very rare disease or it's something that it doesn't exist at all anymore, to look at some of the cost to health services, and to do this through our partnership on the belief that if we develop a methodology, we can use this in different settings in different countries. It took us 5 years to develop this initial methodology. So our aim, develop and validate an international prevalence methodology with an electronic data system to be able to capture data. That was our initial aim. We were provided with a small grant to be able to develop the electronic data set. And all of our frameworks were involved in this. So we had an international team. As you would expect, we did the usual things of having systematic reviews, and it took us 5 years to develop our core data set and to be able to produce something that could be used in a range of different settings, in different healthcares, with different levels of experience. And this is the core tool that is used in all of our LIMPRINT studies, translated into multiple languages, and we own the copyright and the IP because we want this shared. We want this to be used. It's really exciting to have Bulgaria in this call because Bulgaria is doing wonderful LIMPRINT studies, and Arthur as well is also in Uganda doing this. So this is very real, very live. In addition to our core tool, we have other tools as well. So we've got a tool to look at demographics and disability. We have quality of life tools, which are also both generic tools and disease-specific tools. We have a tool that looks at the details of swelling, wounds, and cancer. So there's a range of tools that can be used as modules to add to this. So in our first trance, we had 41 sites in 9 countries, and none of these countries were able to have any funding from the ILF. This came about because academics and clinicians decided together, we are going to make this happen, and we will do this. And these are the countries in the first tranche. And you can see we have a data set of over 13,000 people suffering with lymphedema. And I'm really proud. It's the proudest work I've ever been involved with in my life. It's because we didn't have money, but we made this happen. And we got data from many different sites and many different settings. So we have data about lymphedema services, the kinds of patients that are seen in different settings. We did the very first studies looking at who suffered in acute hospitals. We got studies from outpatient facilities, from community nursing services. We even have a study done in a prison in London, in Nottingham, in UK, in nursing homes. And what is unique about this particular way of working is we collectively own this work. So Bulgaria also is part of the overall ILF LIMPRINT. So this means we can collectively share this, and this has much greater power when we're trying to influence policy. So for instance, I just share a few of our results. All of these are published in Lymphatic Research and Biology and in other papers, in other publications as well. But we went into acute hospitals and we examined every single patient who were in hospital, not for their lymphedema, but for non-related. And we found 38% of the people were suffering with chronic edema. They were never being diagnosed, they were not being treated. 25% of these had both lymphedema and cellulitis in a wound. So this was the first time that people began to think, gosh, this is something affecting acute hospitals. And this has been replicated again in other settings. We wanted to profile the kinds of special services that we were seeing. And these were in UK, in France, in Italy, and Turkey. And of course, these are very different service models. So we found that the 17% of the patients in these services had primary lymphedema, but still 82% of them have secondary lymphedema. 37% of them, it's due to cancer, but often it's due to a range of other comorbidities. So we are learning the importance of diabetes and of morbid obesity. 18.4% are supermorbidly obese. So these specialist centers are also a reflection of what is happening in lymphedema worldwide. And the other extreme is we were able to look at primary care services. So this is a study in primary care. This is people living at home, are frailest people who are in receipt of nursing care in their homes. And we were able to physically assess 2,500 people in receipt of community nursing care over this study. And we found 60% nearly had got chronic edema, never diagnosed, not treated. 73% of them had a concurrent leg ulcer with a mean of 5 years duration. So this was astounding to me that we had this. So we really can see that this is a hidden problem in primary care as well in the UK. So we came to the end of this, and you, of course, this is there are 26 publications actually relating to this, but we are now in the process of adapting this for low-income countries, and I know Arthur is going to share much more of the work he's doing in Uganda. And we are adapting as well LIMPRINT for other sites. And so I'm seeing work in Saudi Arabia has now completed their work looking at it in people having rehabilitation. And Mariella is doing work with Petia in Bulgaria as an example. And in India, we have 11 sites that are doing LIMPRINT in a specialist model. So this is a very live, a very living project, and we are really proud of it. And I know that you're going to see more of Arthur, but this is the reality, the realities of studying in Uganda, and I know Arthur will share with you. And there's not many people that have to dig their own roads to actually get to their research site. But this is the team actually reaching Uganda. And Arthur will share with you something around these people they cried when they saw the teams. And it shook me to realize they said to the team they had never seen a doctor or nurse about this ever. And it really, and they rely on their witch doctors to provide treatment. So we have a huge international challenge ahead of us in these countries. But in India, there's amazing work that is happening. We are in partnership with a project with Dr. Narahari, funded by the Melinda Gates Foundation, with a model of care that is being replicated in 11 regional sites already. And they are transforming the care of people in India. This is the British Journal of Dermatology publication that came out at the beginning of this year. And what they managed to achieve is incredible, a 25% limb volume reduction. Initial cellulitis rates at entry were nearly 85%, and they completely got rid of cellulitis just by their integrated care model, and improvement in every domain of their health-related quality of life with almost no funding at all. So I think this gives us really courage that even in the poorest setting, it's possible to change lives. So with ILF and with the frameworks, we are very much a family. And LIMPRINT is just one example of work that we're doing. But we are trying to uncover this hidden problem in order to inform policy and practice and change the world's views of what lymphedema is. And to recognize that it does affect the poorest, not just in places like India and Africa, in high-income countries. In France, people with lymphedema in the lower quartile. So these people are really impacted, and it's hidden in many, many areas. Complications like wounds and cellulitis are present, but these are all modifiable risk factors by providing treatment. So I would like to finish by just saying I would love to invite you to come next year to our 12th International Lymphedema Framework Conference. It's going to be in Niagara. I know that Petia and Mariella are going to be there, so is Arthur. And we would love to see you, to come and welcome you to share more about this work. Thank you very much.
Christine, Christine, thank you so much. Actually, I can comment a lot about this, and I haven't seen all this too. Maybe I will also only say that as a traditionally educated breast surgeon, this is also very much new information for me. So I think I also learned a lot, and we learn a lot from this. And I remember with Carmela, we always talk it's a problem not for high-income countries, but we see now it is actually a problem for high-income countries. Maybe it's underdiagnosed, and yeah, so many things. But I would like to keep on, and we'll keep the questions and answers for the end, because I know that everybody has a lot of things to say. So I will give now the floor to Artur Bagonza from Uganda, who is also part of the LIMPRINT study and from the framework. So Artur.
Thank you very much, Mariella. And thank you very much, everyone. Allow me to share my presentation. And allow me to say thank you very much, Christine. You have really made my work easy. Ladies and gentlemen, you're welcome. We're from Uganda. I have quite a number of colleagues here online. In case I get stuck, I'm sure they will come in to help me. And my name is Arthur Bagonza. I work with Makerere University School of Public Health. We have been at the forefront of making sure that we reach out to people with lymphedema. But as you all know, in Africa, we are really troubled with lymphatic filariasis because of the mosquitoes. And I'm going to just take you quickly so that we catch up with time. Mine will be mainly photos. Christine has done a lot of the background work, so I'll not find it very hard. So we would like to, first of all, declare no interest as we present. And in Africa, because we do not have very high technology, we have relied on the basic principles of care for people with lymphatic filariasis. And it is not until recently that we were able to see some high-tech technology coming down to Africa, and I'm going to share with you what I mean by that. But most of the care that we've been really experiencing has been basic, like you're going to see. And I would like to start with skin care. That is one of the persons living with lymphedema. And, you know, because people have not been having the knowledge even of how to care for their skin, for example, using soap and water to clean the area that is affected. In Africa, we have very good shea butter. I don't know whether many of you know it. This is very protective when it comes to sunshine and bacterial entry. And we've also come to encourage patients, especially those who have cellulitis, to use antibiotics. And these have been prescribed by doctors. And we are trying to see that the VHTs is the smallest level of healthcare workers that can use the antibiotics. But because the knowledge is limited, we are still trying to find a balance on how this can be done. But all this I'm telling you is not more than 5 years old, and the thing is still catching on. Some of these patients, like Christine has told you, have not seen a doctor. We went to island districts in Buvuma, and we also went to Napak in Karamoja, and some of these people had not seen any form of care for lymphedema. So as far as compression is concerned, again, you can see that lady with the compression socks. And I would like to tell you that most of these things that you people will see in Europe and take for granted, to us, that is really gold. That sock you see there was donated to that lady, and I think you can see we covered her face, but you can see that she was really, really happy. Most of these garments are very, very expensive. And even when we try to import them, the taxes make it really prohibitive. We know that part of the care for lymphedema involves exercise and elevation. And on the right there, you will see Professor Christine Moffat. He was showing one of the people how to elevate the leg. That gentleman there happens to be my dad. So you can see the passion with which we operate. And we know that simple exercises, for example, in India, Professor Christine, I think, should have talked about this, Ayurvedic, yoga. So people do these kind of simple exercises to, you know, to help with lymphatic flow. Then we also have MLD, and this, like you've seen in Professor Christine Moffat's presentation, if you see on the bottom left, that is in India, and that is at Dr. Narahari's clinic. And we shall be going to India very soon to get more expertise on how manual lymphatic drainage is done. And we hope to spread this knowledge to, like I told you, the lowest level in our districts. We hope to show the VHTs how this can be done, so that we spread the level of care, which is generally lacking. And Christine also tells me that she has a grant, and we want to see how we can teach more people through an education program at an opportune time, how we can care for patients with lymphedema. Now, like you heard, there are also other causes of lymphedema. And in Africa, you're always seeing on the news how we have malnutrition. Malnutrition is a very big challenge, and this is also being exacerbated by climate change. A lot of crops and a lot of famine is really making matters worse. That child, if you look at the legs, that child has bipedal edema when you press on the legs. So this, while we talk about lymphatic filariasis in children in Africa, we are looking at severe malnutrition as one of the contributors. So when we look at the supplies, Christine has told you in India, they have started making bandages for $1. We are in the process. We have 2 students who are planning to do their PhDs on compression. And we hope with their studies, we can have something cost-effective for Uganda. But right now, we're relying on donations. And recently, when Christine and her husband came to Uganda, we were very lucky to get donations from Sizetsa, a very small company, but with a very big heart. So the people we gave these gametes are very happy. And I must tell you at this point that even when we try to use the normal bandages, people in Africa mainly live in the rural areas, they go to dig. So the bandages kind of get off the limbs. The arms are really uncomfortable. You can't dig, you can't use a hoe with the bandages. So with this kind of gametes, people are really very, very excited, and they've been asking us for more, but we'll have this talk with this at an appropriate time. Education and empowerment, we did a study in those two areas, and most of the people, like you see those people in the rural areas, think this is witchcraft. They think when you jump over a garden, someone's garden, you'll develop lymphatic filariasis, the legs will become big. So there is a very, besides the management of the patients, we really need to dispel the myths among our populations and really develop some good education materials, just like what Mariela and her colleagues have developed. We hope with these simple manuals and IEC materials, we can spread the knowledge among affected communities, because the people who have this lymphatic filariasis are really stigmatized. People don't sit next to them. People don't want to eat with them. They don't, they just leave them to be alone, okay? And this really has a very big effect on their psychology. They feel, one of the people interviewed said they feel like committing suicide because they're outcasts in society. Now, this is my second last slide. This is the high tech that I told you. We've had some visitors from Germany, and one of them is called Professor Ong, who has come and done surgery on a few people. And so far, the results are good. But like all of you know, these techniques take long to learn. And even the machines that do these things are really difficult. But this is one of the success stories. The lady there had a very big leg, like you can see on the left. But with time, you can see what she says. She feels really amazed that she can now walk like a 25-year-old. Not much of this is available, and so we really like to stick to what we can afford and what we can manage. And well, with time, when these technologies are known and available to us and are effective, perhaps then we can adopt them. So some of the challenges, which is the highlight of today, is that these are the challenges we really face: resource limitations. We have a shortage of expertise. We have healthcare infrastructure. When we looked at the statistics of people who were going to health facilities, we found that only 17% of those who had lymphatic filariasis had visited a health facility in the past 1 year. Only 17, and they had gone there only once. And when they reached there, the healthcare workers didn't know what to do for them. So this is really a double-edged sword for us. And we hope that with the team here and with the people who are out there, we can combat this challenge together. And this is not only in Uganda, even in Tanzania, in Congo, Burundi. All these countries have similar challenges because of the lack of expertise. I would like to thank you very much for listening, and we shall welcome questions. Thank you very much.
Thank you, Arthur. And there's a lot of things still going on. And there was questions at the end. So we keep on going. And our next speaker, I'm very happy to introduce Petya Stojeva. She's from the Bulgarian Lymphedema framework, and she's actually the person who get me involved in international lymphedema framework, and making me really work passionate about the Lymphedema Society in Bulgaria and abroad. So Petya, are you here?
I'm here. Hello. Hi, Mariela. I'm trying to share my presentation. I think I will. I think I'm ready. Hi, everyone. My name is Petya Stoicheva, and I'm one of the founders of Bulgarian Lymphedema Association. I also have been a patient with the secondary lymphedema for over 13 years. Today, I'd like to share with you my experience like patients and tell you about some important aspects in lymphedema management that I believe could be improved with the support of the specialist like you. Lymphedema is a hidden epidemic. Because of the lack of enough clinical research in this area, lymphedema is under-recognized as a disease, and awareness among the public and medical professionals is still low. This is the reason for the delayed diagnosis and treatment, which complicate the condition and reduces patient quality of life. Lymphedema requires complex and consistent treatment, but many patients don't receive the care they need because of the lack of researches and the resource of medical specialty services. Living with lymphedema is a daily struggle with discomfort and limited mobility. Patients often experience pain, swelling, and feeling of heaviness in the affected limbs. Simple activities that others take for granted can become a real challenge for us. Wearing compression garment, applying therapy treatment, and caring for the skin are an essential part of daily life, but are often overwhelming weight for the patients. Many of us are feeling social isolation and have a low self-esteem because of our body change shape. The lack of patients' awareness and education make it even more difficult to manage symptoms and improve our quality of life. In the desperation, some patients are looking for solution of questionable therapies that can lead to more serious complication of their condition. Patients with lymphedema urgently need new and effective therapies to relieve their symptoms and improve their quality of life. That's why there is a need to increase investment in clinical research to develop treatment innovation that will provide us better options in the future. As a patient, I would like to see more studies available to us that offer a practical solution to integrate into daily life. Regular and clear communication with the doctors and specialists is essential. They need to understand my problems and challenge I face every day. Their support and empathy are invaluable. I believe that clinical trials will contribute a better understanding of the disease by medical professionals. They will provide access to accurate diagnosis and treatment, and also increase the number of trained therapists and lymphedema treatment centers. In next two slides, I have briefly described what are the main motivation of lymphedema patient to take part in a clinical trial, what are the fears, and what help to increase the interest in such participation. First of all, of course, is the hope of the improvement of the condition, access to the latest technology, and sense of contribution to medical science. However, there are some patient fears that need to be taken into consideration. This is fear of the worsening of the condition, worries about the about the side effect, or fears of unknown. That's why detailed description of the potential benefits, the creation of community among the participants, regular communication and support, and the sharing of success stories from other studies could help more patients to join clinical trials. Besides the evident medical and educational benefits, it is important not to forget the psychosocial benefits of patient participants in the clinical trials. This is the meeting with other patients, the feelings of contributing to society, the active participants to healing process, the feeling of support from the medical teams, and reduction of the feelings of the helplessness. When the patient with lymphedema enroll in a clinical trial, they expect that they will help find a treatment, lead a complete cure. Sorry, it's lead a complete cure or significantly improve their condition, stop the progression, and return them to their normal lifestyle. The patients expect the treatment to be comfortable and less invasive, as well as from pain from discomfort. A very important aspect, it's also emotional side of expectations, such as understanding from the medical teams, emotional support, feeling of control of the disease, hope of the future and improvement of quality of life. Lymphedema is much more than just a medical diagnosis. This is the daily challenge that turns millions of lives around world upside down. And yet it remains one of the most underestimated chronic diseases in modern medicine. This is, it's time to recognize it as social significant diseases requiring urgently global attention and action. As a lymphedema patient and representative of the Bulgarian Lymphedema Association, I hope to inspire you to look beyond the statistic and see the real patient behind the diagnosis. Clinical trials are not just research, they are a bridge to a better future of everybody with this condition. I believe that the key to real progress in the fight against the lymphedema is a true partnership between patients, doctors, and researchers. And now, thank you. Sorry.
Thank you very much, Petya. It was wonderful. And I will only say that when I was listening after lecture and your lecture, I can say Bulgaria is for the first time classified as high-income country in this year, but I don't see many difference in the problems in front of lymphedema patients from Bulgaria and from Uganda, and the social isolation and all the support that they need and the wishes of all these patients all around the world seems very similar. We will continue to our last speaker. This is Nele from Belgium, and I hope she will give us the bright side of future of lymphedema. So please.
Okay, hello everybody. I hope you hear me. I also test whether you can see the arrow on the screen or not.
Yes, we can see.
Do you see this?
Yeah.
Okay, perfect. Indeed, I'm Nela, working as a clinician in the hospital in Leuven, and I'm also a researcher there. Yes. First of all, I will discuss a little bit the structure of my presentation. I will discuss the evaluation, conservative treatment, surgical treatment in different types of lymphedema after surgery for oncology. That is so arm lymphedema patients, leg, breast, and genital. First of all, of the different topics, I will discuss the literature, and thereafter I will discuss the research needs, and then you see also this question mark. When I discuss the evidence, first of all, I will discuss systematic reviews, and then you see it like this mentioned. Thereafter, if I do not have a systematic review, I discussed a randomized control trial or a guideline, and I did my search in PubMed. Now, if we want to evaluate a patient with lymphedema, we of course evaluate the volume and the local tissue water, but we also have to evaluate other impairments in function and structure. We also have to evaluate the activity limitations and participation restrictions of patients, and of course, the environmental factors and the personal factors that has an influence on the complete level of problems in functioning. Now, if we discuss the evaluation of our lymphedema, and we have in literature a good quality of life questionnaire, the lymph ICF, the LYMPHCOL questionnaire, with good clinimetric properties. We have a value for our standard error of measurement, smallest real difference, which are important to interpret the results. To evaluate the volume, we have 3 different methods, also with very good clinimetric properties. More recently, we have a tool that also can evaluate the local tissue water. There are less studies about this tool. We already have a little bit good clinimetric properties, but not so much. For the evaluation of leg lymphedema, we also have good quality of life questionnaires, again, the lymph ICF, also the LYMPHCOL. Unfortunately, for the LYMPHCOL, we have not a value for the SAM and SRD. For the evaluation of leg volume, food volume, but also local tissue water, we have less studies. So on this part, we really still have a need. There is also a systematic review about the evaluation of breast edema. And for evaluation of breast edema, ultrasound is recommended, but this information is only about one study. The evaluation of local tissue water, but also using breast edema questionnaires, have to be further investigated. And then about evaluation of genital edema, we completely have no studies about. So what are my research questions? The clinimetric properties of evaluation of leg lymphedema, it means the volume of the leg, the volume of the foot and local tissue water has to be confirmed. And the evaluation of breast and genital lymphedema has to be completely investigated. Let's move to the conservative treatment. Now, there is consensus that the best treatment for lymphedema is a decongestive lymphatic therapy. And it means if a patient has spitting or there is presence of wounds, we first have to perform an intensive treatment. It means that we treat a patient on a daily basis during 2 or 3 weeks. And what do we perform? Skin care, exercises, if needed, also lymph drainage, wound care, and guidance by psychologist, dietitian, and social worker. Now, of course, in this period, we also apply compression therapy. And as compression here, we apply bandages. And we also educate our patients so that they are able to perform self-management. What is the aim of the intensive phase? That we reduce the edema in this short periods of time and that we improve already the other problems in functioning. After the intensive phase, we start a maintenance phase. And the treatment components are the same, but instead of bandaging, our patients receive a compression garment, and we also stimulate the patients to perform self-management. What is the aim of this phase? That we stabilize the edema volume and that we work further on the improvement of the problems in functioning. Let's now discuss the different parts. And let's start with the skin care. And the purpose is that we reduce the load on the lymphatic system. and that we also avoid infection, called cellulitis or erysipelas. Now, unfortunately, in literature, the added value of the skincare to the other components of the decongestive lymphatic therapy has never been investigated. Let's move then to the manual lymph drainage. We have a couple of studies, and you find them in the graph, in patients with arm lymphedema. Now, the result is that manual lymph drainage has limited added value to the intensive phase of the decongestive lymphatic therapy. And you see the result here on the bottom of the graph. Now, in addition, in arm lymphedema patients, the added value of MLD to the maintenance phase of the decongestive lymphatic therapy has never been investigated, and also not the added value of MLD in patients with leg, breast, and genital lymphedema. Let's then discuss the compression. Now, recently, Webb has performed a very interesting study, and they investigated the added value of compression in patients with an episode of infection, of erysipelas. And they showed, and you see it in the graph here on top, that patients who received compression, that they had less recurrence of the infection than the patients who did not have compression. And so this is really something important, and it shows that compression is really necessary to avoid recurrence of infection. Then I will discuss the bandaging in the intensive phase. So based on the study of Betcher, they showed that bandaging in the intensive phase gives more reduction of the volume than when patients immediately receive compression. And you see that there is really a difference in the volume reduction immediately after the period of bandaging, but there was also really a difference in volume reduction in the long term. Now, why is this volume reduction important? Because this volume reduction gives an improvement of the mobility, depression, appearance, and quality of life. Now, which kind of compression or bandaging do we have to apply? It's equal. So you can apply non-cohesive bandages, but also cohesive bandages or Velcro bandages, and they give comparable results. Let's discuss then now pneumatic compression. So in patients with arm lymphedema, the pneumatic compression gives an additional reduction of the arm volume. Now, unfortunately, the added value of pneumatic compression in patients with leg, breast, and genital edema is unknown. Then the discussion of the compression garment. The compression garment in patients with arm lymphedema gives a stabilization of the edema, but again, information about the effect of the compression garment in patients with leg, breast, and genital edema is also unknown. Now, in clinical practice, we often advise our patients here in Belgium to go for flat-knit, custom-made compression garments, but also this has never been proven that they are superior to the round-knit standard compression garments. Okay, let's move then to the next treatment modality, the exercise therapy. And so in patients with arm lymphedema, it has been proven that it gives a volume reduction. Yeah. Now, especially resistance exercises gives this volume reduction when treatment programs are applied less than 12 weeks, when they are fully supervised. And here you see that especially in patients with arm lymphedema, studies are performed and not in patients with leg lymphedema. In addition, one study also showed that it's not necessary to wear the compression sleeve while exercising. And like you can expect, also in patients with leg, breast, and genital edema, we miss studies about the effect of exercise therapy. Now, this exercise therapy in patients with lymphedema is not only important to reduce the edema volume, but it has also other effects. It has a positive effect on pain, on quality of life, disability of the upper limb, on the strength, fatigue. Again, unfortunately, we missed studies about the other outcomes in patients with leg, breast, and genital edema. The last slide about conservative treatments. So we also have a lot of attention in our practice to improving the lifestyle of the patient. So it means increasing physical activity level, weight reduction, with this lifestyle counseling, but also the evidence of this lifestyle intervention is unknown. And then finally, the evidence of education to improve the self-management. It has been demonstrated in patients with arm lymphedema that self-monitoring improves self-management and that self-management reduces the pain and the edema volume. But again, studies in patients with leg, breast, and genital edema are missing. So what can we conclude regarding the conservative treatments? That at this moment, added value of skincare and lifestyle interventions are unknown, and that also information is missing about the added value or the superiority of flat-knit custom-made compression garments over round-knit standard compression garments. And of course, like I mentioned already several times, we really need randomized controlled trials also in patients with leg, breast, and genital lymphedema. Then the last part of the discussion, the surgical treatment. And at surgical treatment, liposuction or circumferential suction assisted lipectomy is already performed for a very long time. When is it performed? If a patient has a lot of adipose tissue and has problems in functioning because of this adipose tissue, and patients after the liposuction are recommended to wear their compression garment 24 hours a day on a daily basis. And my question is this really necessary? Because for a lot of patients, this is really a barrier. You can also see on the two figures that after a liposuction, the volume reduction in the arm, in patients with arm lymphedema, but also patients with leg lymphedema, is really good. And they can also keep the result in the long term. Let's take a look now to the other surgical treatment modality, the reconstructive lymphatic surgery, which can be a lymphovenous anastomosis, but it can also be a lymph node transfer. When is it performed? If patients have received at least 60 months of good conservative treatment, and if there is no stabilization of the edema, or if there is a history of multiple infections. Now, the last systematic review that has been made stated that robust evidence of this reconstructive surgery is missing. And we have 2 randomized controlled trials in patients with arm lymphedema. One randomized controlled trial concluded a non-significant added value of lymphovenous anastomosis on the quality of life. And another randomized controlled trial showed an added value of a lymph node transfer on arm volume reduction. And we also have one RCT in leg lymphedema, and they showed an added value of LVA on the infection rates. So what can we conclude here? So the need for 24-hour compression after liposuction has to be further investigated, and also the added value of reconstructive lymphatic surgery on top of the conservative treatment has also to be further investigated. So I want to thank you for your attention. I hope you liked my presentation. So as you can see, we already have a lot of evidence about treatment of lymphedema, but we still miss some things.
So Nele, thank you very much. Well, what I got is that I have a lot of research, but we still don't have the answers that we need. So, yeah, okay, then we have to do more, obviously. And in line with this, I would like to highlight just two things to share with all of you. So first, I think that LIMPRINT study, it's very good idea and it's very important and it's very easy, because usually on the ESSO webinars, there are a lot of young surgeons who wonder, maybe search for some research topic that could be easily implemented in their practice. So I really think that LIMPRINT is such a topic, and it can be very much used for good at the end, because also the burden of lymphedema is not very well known everywhere. So please, if you wonder what to do, you can do the LIMPRINT study. Secondly, I wanted to highlight that there is another project that we are preparing with the International Lymphedema Framework and ESSO, and with PETIA particularly, and it's a survey study about the knowledge of medical professionals on lymphedema, and we hope to open the survey in the next year, in the beginning of 2025. So please, if you receive an email invitation from us to respond the survey, don't miss it. Please respond. This could be also very, very helpful for us. Yeah, and then I would like to open the floor for any questions that we have. I know that there are questions, so please, who will go first?
Maybe we can go for the first question. Actually, I mean, several questions have been answered already by our panelists on the Q&A portal, but there's one question remaining. How can diet reduce lymphedema, or modification of diet, can it help in the reduction of lymphedema? And if so, what kind of diet will be prescribed, or is there any evidence for that or something?
Yeah. Now, there is not so much evidence about effect of diet, but if we first of all think about the risk factors of developing lymphedema after oncology treatment, high BMI, so overweight, weight, and obesity is always being found as a predictive factor for developing lymphedema. So based on this, we really expect that if patients lose weight, the risk of developing lymphedema will be decreased. But also in clinic, we really see if patients lose weight, they can move better, they are more mobile, they are more able to apply self-management, they also feel better in their body, and this is also really positive for the lymphedema. Now, there is one small study in patients with arm lymphedema, and they showed a positive result on the lymphedema, but there are no other studies who have really investigated the effect of diet. Now, my colleague here in the hospital, she has done a study, but it was a pilot study on the effect of ketogenic diet. And she included some patients with arm lymphedema, some patients with leg lymphedema, but it was a very strict diet. And she saw some changes on the lymphatic system. And now she is, she hopes to get funding for a very big trial with a good sample size to prove also the effect of this ketogenic diet.
Thank you for that. I guess maybe I will start also with one comment and then maybe two questions. to our panelists. So first comment, well, I was very much struck by the presentation, I think by Arthur, about, mentioning about the effect of climate change actually on the problem of lymphedema, and how this condition really highlights the disparities in our treatment landscape. And I think many people also said it, that it is a problem of the poor, not just in the poor countries or low resource countries, but also in the high income countries, but in the poorest or the most marginalized populations in this particular in different settings. So that is really an important sort of parameter for us to consider, because by addressing and by knowing more about this condition, then we are probably helping to close that gap. So that was an eye-opener for me, really. And maybe two questions. When should we perform the evaluations? Is it of lymph? Maybe I'm speaking a bit more on the setting of breast cancer. When are they supposed to evaluate? Is it right before surgery, right after surgery, or for example, should it be done before neoadjuvant treatment? When is the timing to evaluate the baseline measurement, let's say, of the arm for breast cancer patients in particular? And does neoadjuvant treatment have any effect on, let's say, the risk of lymphedema?
Shall I answer? I can, but it's again. Is it okay that I answer?
Yes, please.
In an ideal situation, you evaluate the patient before the surgery. And more ideal, it's even also before the adjuvant treatment, especially if the patient receives Taxol chemotherapy, because and lymph node dissection and Taxol and radiotherapy are risk factors also for developing lymphedema of the arm. So in an ideal situation, you measure both arms, and it can be simple circumferences before the surgery. Yeah.
Thank you.
The big problem, in fact, is also because I did my PhD in breast cancer patients, and I made a graph of the arm volume difference of patients before the surgery. And if you, because at that moment they did not have edema, but some patients already had or like to have edema because they had such a difference in volume between both sides. And because of the dominance, you already have more voluminous arm than the other one. And especially the patients who are treated on the dominant arm, they have a little bit of a problem because the non-dominant arm is most of the time less voluminous. And so first of all, this arm has to increase and then have to gain more and to become over the volume of your dominant arm. Mm-hmm. And so we miss a little bit faster at the developing of an edema.
Okay, thank you.
I would like to ask the panelists one question that I think is also related to the question in the Q&A. So what would be the most effective treatment in lymphedema? I will ask it another way. Do you think the surgery will be the final treatment of lymphedema or no? Because as a surgeon, it bothers me. Christine, what do you think?
Well, I think it depends on the surgery, to be honest. I mean, Nella's described the kind of the state of the art as we know it now. I have to be honest and say that what we see in radical debulking surgery, for instance, in India, this is still being done. And Dr. Nahari has a data set of 1,800 patients followed for 10 years. And one of the most important risk factors for poor outcome is radical surgery, the debulking surgery. So although they may do very well in the early postoperative time and they appear to have a massive reduction in volume, they'll often go on to have complications like chronic osteomyelitis, fistula, sinuses. So I think it depends on what surgery we're talking about. I think that surgery is going to play a very important role, and I think we're learning much more about it. And I think probably the investment is also going to be in this area and probably in the area of genetics. So I think maybe I'm not answering your question, but it does depend, I think, on the surgery. I think people like Hakan Bråsen have shown powerfully the role of liposuction in the lymphedema patient group. But as Nella said, the caveat for that is they need to wear compression all the time. And he's always very honest and says, in the group who do not adhere to compression, they're the ones with the poor outcome. So yes, we need surgeons. We need all of us, I think, to work in partnership. And I think I'm really passionate about the early surveillance work, actually getting surgeons to be aware. I mean, some of the work that I have clinically done has been with orthopedic surgeons pre-knee and hip replacement. And at Nottingham, they recognize that people in the lymphedema service who are under our care having a knee replacement, a hip replacement, they did better, which is not surprising simply because they're wearing compression. So I think surgeons working alongside a conservative is really going to be the ideal.
Thank you.
Maybe
Yeah.
I'll just take on to maybe help elucidate the answer to that question. If a person is seen for the first time with lymphedema, whether they were previously known and followed, what would be your first mode of therapy, or what mode of treatment would you offer them?
Shall I start and then the others come? Well, I wish there was kind of international agreement about when to use bandaging and decongestive therapy, when to use hosiery, for instance. Conventional recommendations are that if you have a soft edema, so what we mean here is a fluid-driven edema, then you start with decongestive therapy with bandaging, rather than going into compression hosiery. So that's the conventional. There is not really, we don't have an international standard that says this is the categorization that must start with bandaging and this is the categorization that start with hosiery. We are still largely driven by international consensus on this, and partly because we don't have studies that have examined this. And in fact, I mean, I think Nella and I share the same goal, which is we need studies on compression therapy because they really are lacking. As a clinician, I would say when I have a patient in front of me, I'm always very cautious of using hosiery. If there's a lot of swelling and the skin is very friable and very fragile, I will always very, very careful about putting hosiery on a patient like that. But Nella, you have maybe a different view on this.
No, we do completely the same. And yeah, in some patients, it really must be the order first bandaging and then giving compression garments, because I just had a patient this afternoon and she wears her compression garment when her volume was 6% less. And she says, it hurts so much. Of course, this compression garment is too small, is for a lymph who is less voluminous. So today she had a lot of pitting. So it means, and I proposed her, first we have to do the bandaging again, only maybe 1 week, because she really had a lot of pitting, to be able again to wear a very well compression garment that feels comfortable. If it hurts, you really do not want to wear it, and she will wear it less, and the volume will increase. So this is really important, and it's really, like Christine said, clinical examination, looking, okay, is it necessary that we first perform a reduction of the edema volume before we can have fitting of the compression garment?
Maybe I have a question for Arthur and for Petya with regards to the communication. What's your advice? Because we heard a lot about the stigma that is associated with the condition. So what is do patients with this problem, do they come to the community with their families? Do they come alone? I'm imagining that, of course, those with really massive lymphedema, they will need the support of someone to bring them to the doctors. But what is the advice on communication? And how do you bring in the caregivers and the family for for the educational part of the treatment?
Okay, Petya, do you want to answer or should I go first?
Okay, let's you be first.
Okay, thank you. Thank you for that question, Camilla. And this is something we've really, we are grappling with, because here in Uganda, most of the lymphedema, like I told you, is due to lymphatic filariasis. And we've had two challenges. One, all the females that we visited, all the women who were once married, were deserted by their husbands. These men say, it's a curse, you were bewitched. So that is a very, very high level of stigma. And also the men, only that, we live in a patriarchal society. So most of the women hang in there with their husbands. But I sent Christine a video of a man who was divorced by the wife. She went and got married elsewhere, had 2 children. And when things got bad the other side, she came back to this gentleman. And the leg was really, really, in a bad state. So stigma is something that is very, they even have names for these people when they are working in the trading center. So there is a very big element of education that we need to do among the community. But there is a second challenge. The best way of preventing lymphatic filariasis in communities is by giving antifilarials such as ivermectin. But if you all recall, during COVID, ivermectin
we lost a little bit Arthur. Wait.
So do you want to continue? Maybe you can answer with your perspective, and when Arthur's connectivity allows, he can complete his answer.
Maybe Petya can maybe take over first, and then when Arthur is back,
Yeah,
then
I will try. Yes, the patient with lymphedema have a lot of challenges, and the communication with the friends and family is sometimes very difficult. I know many patients with lot of problems, but they don't explain nothing. They stay at home, they have a colleague, they have a friends, which they don't know about this problem. But when you make our Bulgarian community, Bulgarian association, Bulgarian Lymphedema Association, the patient in Bulgaria slowly they start share their problem. Now it's much easy. When the patients see that they are not alone, they have a lot of patients like them. This is condition is not for shame. We have support of the doctors. This is much more easy. For example, for me was very difficult first, second year. But when I take control of my lymphedema, now it's much more easy for me. So it's one thing which is very important. I think this is for me it's much, and for my patients also in my community, for us is very important to be active, not to be very beautiful. We know that this condition will be with us probably all life, but to keep our activities every day, to live normal is very important. So when our families understood that, they support us. It's only everything is a knowledge.
Thank you. Thank you so much. I just wonder, in matter of time, should we try to respond some of the questions in the Q&A section? So maybe I go to respond first. Do you do preventive lymph surgery in cancer patients? And I think the answer is yes, if you can. There is the study for anastomosis surgery during breast cancer surgery. So if you can do it, but usually general surgeons cannot do it, then you can do it, of course. Then the second question is, what kind of pneumatic compression machine is proven to be effective on lymphedema? I don't know who can answer this.
Well, I say something, and then I'm sure Nella will have something. And this is always a very emotive issue, but to be honest, the jury is out about IPC. And I'm one of the researchers who has done very large studies on this and failed to be able to show IPC having an effect when you choose your primary outcome as volume. So I think we need to be careful, but I also know that what patients tell us is it seems to help them around other symptoms. So it may be, Mariella, that we are not measuring the right primary outcome, or we're not choosing the right primary outcome measure. And that may be simply why IPC in lymphedema, we don't have an evidence base yet. If I put my clinician hat on for a moment, some of my most complex patients have been those who are unable to walk, unable to elevate their legs, completely immobile, living at home. And then compression therapy plus IPC can be a really useful clinical tool. So I guess, but it's also expensive as well. So we have to think about that. But Nella, I would really value whether you agree.
Yeah, if you look in literature, there is some evidence in patients with arm lymphedema, but the problem is a little bit, and it was also explained in the study, if the pneumatic compression stops, then the volume comes back. But it's with every treatment, because we do not heal the problem. Another thing that I also want to say is that pneumatic compression is really a passive treatment, and we try to evaluate or try to motivate patients more, having a better lifestyle, to move better, and that they have better strength, endurance, because this makes that our quality of life improves. And we see in a lot of lymphedema patients that they are really in a negative vicious circle. And by moving again, and moving is also a better mental well-being. By moving again, they become happier. They have again more motivation to participate in life. So that's a little bit what we try to do here, is to let patients move, and we do not put a lot of emphasis on passive treatments like pneumatic compression. It can be performed additionally and to support the patients a little bit at home, but it's not our principal treatment.
Okay, thank you very much. What about one last question? Maybe how, because I think it's a general question, and yeah, everybody maybe need the answer. How often should we perform the therapy, the bandages, and then the lymphatic drainage? So, yeah, is there a specific regimen that you are following maybe in this?
Yeah. During an intensive treatment phase, being consistent is very important. As sometimes we have patients and they go to a therapist and only 3 days a week a bandage is applied, and then the rest of the days nothing is performed. Yeah, this is not the treatment that we propose, because it's very important to go from bandage to bandage, and that we stimulate also during this period, and that the patient moves on a daily basis. And it's also walking, or also when they are sitting in the chair, that they move the muscles. We here in the clinic during the intensive phase, we do not perform a lot of MLD. We do only MLD if there is an accumulation of lymph proximal of the bandage, but because the bandage is doing the lymph drainage on the lymph. This is a little bit the way we work. So patient enters the room, we wash the lymph, we hydrate the lymph, we put on the bandage. It takes around 1 hour. And then we go to the exercise room with the patients. And even in patients who are in a wheelchair, we try to move. And this is the treatment that we perform on a daily basis. And then additionally, we organize also real educational sessions. It's really in group, explaining what is lymphedema, what can you do by yourself. We teach them if it's possible to do the self-bandaging. How can I evaluate myself? Why do we choose certain compression materials? And so they receive a lot of information, also practical things, so that they are able to perform the self-management better at home.
Can I add in one of the difficulties we have is in some ways, lymphedema treatment is defined by who is paying for it and organizing it. And we don't have, I mean, in the Netherlands, in Belgium, and Germany, they are considered to be the gold standard. But actually in Denmark, nobody is able to come every day. They're coming at the most 3 times a week. In France, they are commissioned for 1 week of intensive treatment. So some of the things governing what can be done are by whoever is paying for healthcare. But I mean, I think that one of the most dangerous things is for people to not understand, that they are participating, they can change their own condition by participating, if they are not passive in this, but also that immediately you remove compression therapy, you are immediately seeing a reversal of the pressure that's occurring. And you can physically sometimes see this occurring with a patient in front of your eyes. You see the limb swelling and you see it starting to drip with lymphuria. And clinicians do not understand that compression only works when it's in contact with the limb, which is of course obvious, but they somehow believe that the kind of, it will carry on once it's been removed. And this is a really big danger. So we have so many different models of care, and there are so many complex issues that define what is possible.
Thank you so much. And I knew that Raza wanted to ask about the cost of lymphedema. Actually, now this is his time maybe to ask the question.
It's more I wanted to highlight the fact that in my understanding, it's very and you brought up this association that lymphedema affects people in the poorer socioeconomic status. This association may be two-way, and I wanted your insights and input on this, because it may be that it is affecting people who are in the lower socioeconomic strata. But could it be an element of financial toxicity itself because of the treatment, or the fact that they cannot earn, or the fact that the earning member has to support them in their physical and clinical needs? How much of that do you see in practice?
Who you're asking?
Christine, Arthur, Petya, Nella, whoever can
Okay,
answer the question.
just I will comment that in Bulgaria, it's the treatment is not reimbursed, so all the financial burden is for the patients, and there's a lot of out-of-pocket payment here. And this is one of the things that we are trying to do with LIMPRINT, to actually investigate how much actually it costs. So this is my answer. Now maybe Christine, you can go.
I think the issue of who is affected, there is no doubt in countries like India and Africa, the endemic areas for mosquitoes are they are in rural, but they're also in urban areas as well. So there's no doubt that the socioeconomic aspect, and actually I'll let Arthur add as well, but I mean, we have definitely shown the link in the Uganda study with poverty and sanitation. I mean, in Uganda, in the study, there were people without any washrooms or any sanitation or toilets. And Dr. Narahari's work has shown this very powerfully. So it's probably a vicious cycle, really, because the lymphedema drives the social deprivation because people cannot work. And so you are in a cycle, really. But Arthur, I'm sure Arthur has something else to say, being in public health.
No, you've really nailed it, Christine. And we've because of this, we've written a proposal, and we are looking for funding. All of you know that the COP29 climate change summit just happened, and I think they committed about 300 billion. And when you go, for example, to the refugee camps or settlements, this is where you find most of these malnourished children. And one of the drivers, like Christina said, is poverty. But where does the poverty come from? Fuel, because these refugees are given food, but don't have the fuel, for example, to cook the food. So they go cutting the trees, and we see the effects of this climate change. So we've written a proposal even just to say, can we have briquettes? I don't know if all of you know briquettes. They burn much longer than traditional firewood. And we think if that is adopted by most of them, then we'll see more trees growing, and the effects on the environment will be reduced. But yes, this is really a challenge, especially among the rural poor. And we see these effects mainly, for example, when it is the rainy season, the mosquitoes, the numbers go up, the transmission goes up, and during the dry season, the transmission goes down. So these and now the patterns have been, then we would predict that we are going for a rainy season, and then they would distribute ivermectin, mosquito nets, but now it's even hard to predict. So we are seeing the erratic patterns of transmission among communities, and we think with the whole group, we could put our heads together and tap into these new monies that are coming to help the really marginalized people who are affected. Yeah.
One of the things I would like to say about the idea that where you live in the world defines what type of lymphedema you have. I can promise you, when the first time I went to India, the very first patient I saw had lymphedema distichiasis. So of course, just because you're in Africa or India does not mean you don't have a cancer-related lymphedema or a primary lymphedema or a phlebolymphedema. And so there is a little bit of a myth that because you're living in that kind of country, you have to have lymphatic filariasis. I think I've only truly seen one filariasis patient in UK, and he was somebody who came from an endemic area. But the trouble is the WHO have an idea that lymphedema is a neglected tropical disease. And our mantra is lymphedema is a neglected global disease, not a neglected tropical disease. It's a global disease of which there are many causes, there are many risk factors, but suffering and morbidity is the impact. And there is also the issue of drug administration to eliminate filariasis. If you read the mantra from the WHO, they will tell you lymphedema will be eliminated in these countries because mass drug administration stops the mosquito transmission. If you go to Africa and India, what do you find? People won't take the drugs because they're afraid of the medicine, because it makes them sick. 40 to 50% of people refuse the medication. So even in the countries, the solutions are sometimes very complex.
Thank you. Well,
sorry, I just wanted to add on to what Christina said, that in Africa, some communities use mosquito nets to make wedding gowns, to make chicken houses. You wouldn't believe this, but you'll go and you'll find people have used the mosquito net to make a trap where the chicken will be in the evening, or spend the evening, or use it as a gown for the wedding dress. And you know, these all baffle us in public health. We don't know what to do.
But I think what this is, it's really, I mean, we have a little bit of time left, but I think it is a very big problem, but there's also this opportunity here because you know there is this opportunity to collaborate between a high income setting and a low income setting, because the way the treatments are presented, it seems to me that the most important part of the treatment are really very basic treatments, like very and the idea of the treatment is really, in a way, participatory treatment. That the patient needs to move, the doctors need to encourage the movement, the doctors need to be proactive. So there's that opportunity to do research together and to really build the evidence on this very basic kind of treatment. And this is something that will be probably applicable in many settings. But I think the lymphedema framework and infrastructure that is existing is really a good opportunity to build this evidence globally. So yeah, I mean, it seems to be a very difficult problem, but I think there is an opportunity here.
You have made my day. Fantastic.
And I think as well for surgeons to understand that we understand, firstly, if you have cancer, you need treatment for your cancer, but to recognize that in being effective, you may cause a complication, and it's not your fault. You have to do your job. If we are working together, then you know we can, and it's true. It can be. It can be a simple intervention, and but the problem is the world makes even these apparently simple interventions out of reach due to cost. And you know, we have now in northern India bandages that can be made that are really good quality, and yet there is a 300% more cost if you make the same thing in Europe. So there's a cartel really around this. So yeah, I mean, we are committed to trying, and it's wonderful to work with Petia and all the patients, because it's also about taking away, I mean, my passion is psychology, taking away the feelings of shame and guilt that they carry. And that is best driven by patients themselves in this endeavor.
Thank you very much. I couldn't think of better final of our webinar, because we are close to final now. But really, so the psychological aspect, the patient participation, the money, always important. A lot of things. I think we gave food for thoughts and to everybody. So now, thank you all very much. This was my last ESSO webinar. I think I made it the best. So, so really, I hope we can further collaborate and exchange contacts and still working on this. So thank you very much again, and I wish all of you a wonderful evening, and I hope to see you again soon. One last thing I have to promote, the ESSO course in Bulgaria. This is the first ESSO course on basic of oncology for surgeons. So please don't miss it. It will be in March next year, and it's now the perfect time to register. Find more about it on the ESSO website. And I hope to see you soon.